I am going to be reviewing types of spinal cord injuries, starting out with central cord syndrome. But before I start talking about the signs and the causes of this, I just want to kind of go over what's involved, what the spinal cord looks like, the different tracts, because knowing this stuff is going to tell you everything about the type of syndrome that you're dealing with. Okay, so first off, the dorsal columns are here at the top, these two here. It's responsible for proprioception, fine touch, and vibration. Then over here, we have the cortical spinal tract, these two here, these little triangles. And these are responsible for motor. So one thing I do want to note here is the cortical spinal tracts are ipsilateral, meaning that they don't cross at that point. So whenever you have damage to them, it's always going to be same side motor damage. So ipsilateral means same side. Then down at the bottom, these two guys are the spinal thalamic tract. And do note that I put contralateral because the spinal thalamic tract does cross at that point. They actually cross right here at the anterior white commissure. So the spinal thalamic tracts are going to come in, cross here, and go to the other side. So whenever you have damage to those, you're going to have opposite, contralateral, opposite side pain, temperature, and crude touch loss. Okay? Do note the difference between crude touch and fine touch. Fine touch is dorsal columns, crude touch is spinal thalamic tract. Alrighty, so that pretty much covers it. And then I do want to go over this here. So this little triangle is a representation of the cortical spinal tract. The cortical spinal tract has different areas that it is responsible for. So for instance, the most lateral, so right here, lateral, is responsible for the sacral region, followed by lumbar, thoracic, and cervical. Okay, so just note that cervical is medial, sacral is lateral. Okay, now let's talk about the signs. This is going to be important when we talk about the signs. So with a central cord syndrome injury, you're going to see paralysis that is greater in the upper extremities, being the hands and arms, compared to the lower extremities and the trunk. Why? All right. So this little circle here is my central cord injury area, okay? Notice how typically with central cord injuries, it extends slightly into the cortical spinal tract. It doesn't cover it all the way up, but just kind of the tip there. And remember what we said is in the tip of the cortical spinal. It's the cervical and some of the thoracic. Depending on how bad the injury is and how far it spans out is going to depend on how much is affected. But typically, the upper extremities are going to be most affected because they're here. The trunk and lower extremities are going to be less affected because they're out here. Okay? Then we're going to move on to another big one, loss of bowel and bladder. And down, I'm going to skip this one for now and I'm going to come right back to it. I just want to go over the really, really important ones first. This one is bilateral loss of pain, temperature, crude touch. Why? Why do you have bilateral loss of pain, temperature, and crude touch? Well, that's because, look here, the anterior white commissure is affected. It's within that little circle, which is where the central cord syndrome injury happened. So if you damage this area, which remember is where the spinal thalamic tract crosses over, then you got to think, the spinal thalamic tract, there's one on each side. They're both going to cross at this point. So if you lose this point, you lose both sides. So there's no contralateral, ipsilateral, you lose bilateral because you caught it where it crossed. Oftentimes you'll kind of see this written as sensory loss below the level of the injury. So if you see sensory loss, you're thinking pain, temperature, crude touch, because that's the spinal thalamic tract that crosses where the injury is. Okay? And then also, the one that I skipped is sometimes you'll see a patient present with Horner syndrome. And I've talked before, Horner syndrome is ptosis of the eyes or the eyelid, which is eyelid drooping, and meiosis, which is pupillary constriction, so your pupils get small, and anhidrosis, which is sweating or lack thereof. So sometimes you'll see Horner syndrome as well, but what I really want you to remember for this one is paralysis that's more in the upper extremities, hands and arms, compared to the lower extremities and trunk. Bilateral loss of sensory below the level of injury, pain, temperature, and crude touch, and loss of bowel and bladder. And then over here, I just said, typically this is caused by cervical hyperextension, and you'll get cervical hyperextension often in falls. So think of it, when you fall, you get this quick movement here, hyperextension of the cervical region, which is going to cause the domino effect of all of these things that I talked about. Next, we'll talk about anterior cord syndrome. So pretty much with this one, the whole anterior portion of the spinal cord is affected. That's what these little lines are. The only thing not affected is up here, which is the dorsal columns, which are found posteriorly. Okay, what does this look like? Bilateral upper motor neuron lesion below the level of injury. Okay, these lateral cortical spinal tracts are affected. Cortical spinal is responsible for motor, specifically upper motor. When upper motor neurons are affected, it's going to present with spastic paralysis, hypertonia, hyperreflexia, and a positive Babinski sign. Remember, Babinski is where you stroke along the foot and you see the toes kind of fan out. Okay? This is supposed to be positive in babies pretty much before the age of 1. After that, if it's found, it's usually a sign of upper motor neuron lesion, which can be a result of an anterior cord syndrome. Okay? What else will you see? What else is affected? Well, remember, our spinal thalamic tracts are affected. And this time, it doesn't matter ipsilateral or contralateral, because all of it's affected on both sides. So what are you going to get? Bilateral loss of pain, temperature, and crude touch, because that's what the spinal thalamic tracts are responsible for. What else? You're going to see that proprioceptive, fine touch, and vibration are not affected. As I said, the dorsal columns are good to go. I'm also just going to throw in here posterior cord syndrome, which is the opposite of this one. So instead of this area down here anteriorly being affected, the posterior area is affected, causing bilateral loss of proprioception, fine and discriminatory touch, and vibration. I also just want to note here that you're going to have loss of your epicritic sensation. Epicritic pretty much is just your sterignosis. So remember, sterignosis is putting something without looking, manipulating something in your hand and being able to figure out what it is. So if you're digging in your purse, being able to find your keys without seeing the key, that kind of thing. And then also 2-point discriminatory touch, which is if I were to touch your arm at 2 different points, you'd know that I'm touching 2 points separately. I'm not just touching one. Okay? Now for Brown-Sequard syndrome. So this one is when only one side of the spinal cord injury is going to be damaged. So kind of really the same thing that we've been talking about. One side of the cortical spinal tract is damaged. One side of the dorsal column is damaged. One spinal thalamic tract is damaged. So what does that look like? How's that going to present? Ipsilateral loss of proprioception, fine touch, discriminatory touch, and vibration, which are where? In the dorsal columns, the posterior dorsal columns, because half of that is affected. It is ipsilateral because it is still same side. Okay, no cross, same side. Ipsilateral upper motor neuron lesion symptoms. Why ipsilateral? Because it only affects one side of the cortical spinal tract, which is responsible for motor, and there's no cross, so it stays same side. It ascends and descends same side. Upper motor neuron, so you see what? Spastic paralysis. You see hypertonia, hyperreflexia, positive Babinski sign. What else? Ipsilateral. This one I have not really talked about yet, but I did want to put it here because I felt like it was important. Ipsilateral lower motor neuron lesion, and it's at that level, not below. So the other ones were below the level. This one is at that level specifically. All right, so here, the anterior gray horn here is responsible for lower motor neurons. So cortical spinal, upper motor neuron, anterior gray horn, lower motor neuron. When there is a lower motor neuron lesion, you see what? Flaccid paralysis, fasciculations, which fasciculations is like muscle twitching or jumping, hypotonia, hyporeflexia, okay? And since only half of the anterior gray horn was affected, you're going to get ipsilateral damage, so same side damage. Then contralateral. Why contralateral? Because the spinothalamic tract crosses at the anterior right commissure, crosses here. So it's going to be opposite side loss of mostly pain and temperature. Still, maybe some crude touch could be lost as well. So ipsilateral loss of pretty much everything because it affects everything on one side. So same side loss of sensory, of upper motor neuron, and then contralateral, opposite side loss of pain, temperature, and maybe crude touch. Commonly, this is going to be Brown-Sequard syndrome is caused by a stab wound, a gunshot wound, or possibly even a tumor pushing up against and damaging the one side. The last two are Cauda Equina and Conus Medullaris. So the Cauda Equina, which means horse's tail, are the little filaments, little pieces that kind of come off like it looks like a horse's tail. While the Conus Medullaris is that little cone there. It's still a part of the central nervous system here. So the Conus Medullaris, and then there's the Cauda Equina. Cauda Equina is not a part of the central nervous system. It is peripheral nerves. Because they are peripheral nerves, they're able to regenerate. Remember, regeneration is about 1 to 2 millimeters a day. You have lower motor neuron lesion with the Cauda Equina, okay? So remember, we just talked about what happens when it's lower motor neuron. You get hyporeflexia, hypotonia, flaccid paralysis. All right, keyword here, flaccid. Signs, lower extremity flaccid paralysis. Flaccid bowel and bladder may be present. Just a note here, areflexia is just another word for flaccid bowel and bladder. So you might see it termed as areflexive bowel. And then over here, we have the Conus Medullaris. So again, it's a part of the central nervous system. It is a combination of upper motor neuron and lower motor neuron lesion. The signs for this, the lower extremities are less affected. They're not going to be flaccid because it's not fully a lower motor neuron usually. So you'll just see weakness. You'll still have that areflexid or flaccid bowel and bladder. And then pretty much that's it. So the difference is Cauda Equina, flaccid. Conus Medullaris, weak. And areflexive bowel and bladder. So that's the main thing to note here. Now I'm going to talk about what the difference is between an areflexive or flaccid bowel and bladder and a neurogenic or reflexive bowel and bladder. Okay? So pretty much we'll talk about areflexive first, since that's what these two, Conus Medullaris and Cauda Equina, have. So an areflexive bowel is going to be below the T12 level, so lower motor neuron. It's going to be where the anal sphincter is lax. All right, so if the anal sphincter is lax, then there's going to be no reflexive contraction and relaxation of the anal sphincter. All right, so with that, also note that peristalsis is reduced in this, because flaccid, peristalsis is the movement of the, it's going to be reduced because there's flaccidity. What else do I want to know? Oh, interventions. So for this, the OT will teach the client how to do a Valsalva maneuver, which is just kind of like bearing down, like that kind of thing. And then also manual evacuation, so manually removing the stool. So because, I just also want to know, because you're doing manual removal, you typically want the stool to be kind of firm and formed. You don't want it to be loose. So firm and informed stool, so that it can be manually evacuated from the anal sphincter with like a gloved hand or something of that nature. Alrighty, now neurogenic bowel. A neurogenic bowel is upper motor neuron, and it is at or above T12 level. Okay? With this, you have a reflexive anal sphincter. What does that mean? If it's reflexive, that means the sphincter is going to reflexively open when the stool gets to the point of no return, which pretty much means you do have some peristalsis. It may be impaired, but it's still present. The stool will move through with peristalsis and then get close to the anal sphincter. Whenever it gets to a certain point, reflexively, the anal sphincter is going to open. You do not have control over it in either one of these. It's just reflexively going to happen, hence the name reflexive bowel, aka neurogenic bowel. It's reflexively going to happen. The anal sphincter is going to open and you're going to have a bowel movement. Interventions for this are suppository and digital rectal stimulation. So pretty much you want to try to stimulate the reflexive process that's still in place, so that you can try to control when you're having this bowel movement a little better, which is what the bowel and bladder program are. And then just briefly, I didn't really focus too much on bladder, but I'm just going to mention neurogenic bladder is a similar process in which when the bladder starts to fill up, reflexively, you're going to urinate. So not really a controlled thing, just kind of happens. Now I'm going to review spinal cord levels and functional implications for each. So the first level, C1 to C3. This is neck flexion, extension, and rotation. I kind of remember this through movement sequences. So when I think of C1 and C2, it is neck flexion and extension. So flexion, extension. C3 is rotation. C4 is shoulder elevation. C5 is shoulder abduction and elbow flexion. C6 is wrist extension. C7 is elbow extension, wrist flexion, and finger extension. And C8 is flexion of the fingers. And then T1 is the intrinsic muscles, so I just kind of think of it like that. So 1, 2, 3, 4, 5, 6, 7, 8, T1. Okay, that's how I think of it, and that's how I remember it. But back to the board, C1 to 3, like I said, neck flexion, extension, rotation. At this point, the person is probably going to be ventilator dependent. And this is because if we remember, C3, 4, and 5 keep the diaphragm alive. So 3, 4, and 5 are going to innervate the diaphragm. So likely at C1 to 3, they're not going to have the innervation to the diaphragm, therefore they're going to be ventilator dependent. At this point for ADLs, they're total assist. For communication, they may require adaptive equipment. And then at this point, they'll be in a power wheelchair. They need the tilt and recline, which pretty much just means they can recline the wheelchair backwards in order to get some pressure relief. The recommended time is about 30 intervals to prevent pressure ulcers. And then these are just different types of ways that they can control the power wheelchair. So head control, sip and puff, which is they kind of blow into this little thing, chin control, and then a mouth stick. And this is because at this point they can control their neck. So their power wheelchair controls are going to have to come from their head or their mouth. All right, so that's that. And then as far as C4 goes, remember this one is shoulder elevation. At this point, the person may or may not be ventilator dependent. It's just going to depend on the person, but it's possible for them not to be on a ventilator at this point. For their ADLs, they're going to be total assist, but they are going to be able to use adaptive equipment for feeding. At C5, just an example of this, what do I mean by adaptive equipment for feeding? Because they can't use their arms at this point. But what they can use is something called a gooseneck, which attaches to the wheelchair, and it's like this little stretchy pipe thing. And you can attach things like a sandwich holder so they can eat. They can use a feeder so they don't have to use their arms, it feeds them, or something like a long straw. So these are ways that they can eat with adaptive equipment, though they are going to need setup. Okay, and then just a note, at this point, they are going to be using a power wheelchair still, and it'll be one of these, same as C1 to C3. Alrighty, so C5. I told you this one was shoulder abduction, elbow flexion. So think of it like making a muscle. C5, make a muscle. At C5, ADLs, they're going to be modified independent with setup assist. So, eating, they can do some grooming, upper body dressing, but they are going to need some setup assist. They can do a lot more here, though. So you're going to notice C5 is much longer than some of the other ones because they have a lot more functional abilities here. And this is because of the adaptive equipment and because of the splinting and things of that nature. So the splints that will be used at C5 are the long opponent splint. And this is used so that they can hold objects when they're doing occupations like eating, dressing, writing. And the wrist cock up, which is just providing wrist support. Because they don't, remember at this point of C5, they don't have flexion or extension of the wrist. So instead of just having that drop, it'll put it in neutral and support it. You'll also see that I added elbow extension splint as well as a pronation splint. And this is because at this point at C5, now that they have the ability to extend their elbow and to supinate their arm, they can get contractures at this point. So if you use an elbow extension or a pronation splint, it'll help maintain range of motion as that spasticity may increase. And this is due to, again, the risk of contracture with either elbow extension or supination. And then also here down here, I added resting hand splint. So a lot of times they'll recommend that the wrist cock up will support the wrist during the day, and then the resting hand splint can be worn at night. And then some of the adaptive equipment at this point, they'll use a universal cuff. This can be used for many things. You can use a universal cuff when eating by inserting a utensil in, so that now that they have that motion of the arm, that flexion of the elbow is huge because now you can do hand to mouth patterns. And also mobile arm supports. So these are going to go underneath the arm and then kind of help the arm to swing. So if it's a little weak at that point, if the flexion and elbow flexion and things of that nature are weak, the mobile arm support's kind of just going to give a little more assistance to support the weight of the arm when doing activities. And then also down here, I noted that you can drive with adaptive equipment. This is huge, huge, huge milestone for people with C5 injury. And some people, some people can do a sliding board transfer. Typically, these people tend to be more athletic because the way in which you do they have to do it at this point, they would have to externally rotate their arm and do some shoulder depression. So if the person's a little weaker or, maybe didn't have the capacity or strength prior to, it's going to be more difficult for them to do this transfer at this point. However, when we got up here to C6, they should be able to do a independent transfer with a sliding board, regardless of level of athleticism. Most people should be able to transfer with a sliding board. And at this level of C6, remember, this is wrist extension. This is a huge, 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 huge level because of tenodesis. So tenodesis is when you extend the wrist, the fingers naturally flex. You see that? I'm not flexing my fingers, they just do that themselves. So this helps with grasp because at this point they don't have finger flexion. They don't have finger flexion. That doesn't come until what level? C8. C8 is when you get finger flexion. So at this point, they have to use the natural musculature in their hand to cause that tenodesis effect. So ADLs, they'll be independent with adaptive equipment. Again, eating, grooming, upper body dressing, same as C5 pretty much. Males may be able to catheterize at this point. Depending on the person, they may or may not be able to do that. All right. And then I just wanted to maybe briefly touch on some of the adaptive equipment here. I didn't write it, but you can use zipper loops to help them zip up. You can use a palmar cuff with a button hook. You can add Velcro to shoes or your bra. Use built-up handles because now that you have a little bit of a grip because of that tenodesis, if the handle is fatter, you may be able to pick it up to do some more hand-to-mouth patterns and things of that nature. Again, I just want to add a few things. Neuromuscular electrical stimulation. The neuromuscular e-stim can be used to actually enhance that tenodesis. So you stimulate your weak wrist extensors in order to get more of that finger flexion. So you'll see this a lot at that stage. The e-stim can also be used in other stages, like in C7 to increase elbow extension, things of that nature. But a lot of times you'll see it here with tenodesis. Also, I just want to briefly mention that at this point, at C6, they should be independent in pressure relief. And the way they do this is actually by leaning over, so leaning forward kind of over their feet. And for this, they'll need at least 3+, so manual muscle testing, a grade of 3+, shoulder and elbow flexor strength. So if they have less than 3+ for shoulder and elbow flexor strength, they're not going to be able to do this effectively or safely. At this point, it's possible that they may be able to do what's called a depression weight shift, which is typically done at C7. So the way that you do a depression weight shift is pretty much they're going to use their arms to lock out an extension and then use either like the wheels of the wheelchair or the armrest to kind of lift up and relieve pressure. So that's seen a lot at C7 because remember C7 they have elbow extension, but some people, like I said, at C6 will be able to do it. And the way that they do it is kind of by using what they already have. So they will externally rotate, okay? And they will mechanically lock their elbow. So remember, they don't have elbow extension, but they can kind of manipulate it so that their elbow will automatically lock as they externally rotate. So they externally rotate and it kind of locks out. So some people actually will still be able to do that depression transfer at the level of C6, and then at C7 they should definitely be able to do it. Typically the recommendation for like pressure relief is about every 30 to 60 minutes, and this is just going to be until they can determine how long, like what the skin tolerance is. If it can tolerate longer, it can be longer, but the general is about 30 to 60 minutes. Moving on to C7. Remember, C7 is elbow extension, wrist flexion, like this, and finger extension, okay? So I think of C7 like, will you marry me? Like like when someone asks you to marry you and you put your hand out like that to like put the ring on. I don't know why, that's what I think of, and it helps. And 7 is my favorite number, and I want to get married. So boom, there you go. For this level, ADLs are independent with adaptive equipment. Again, eating, grooming, but this time we added in upper body as well as lower body dressing. An individual at C7 may need assist, or they may be able to do this independently with the use of adaptive equipment. So just keep in mind lower body dressing is added here. At this point, oh, and then also, what did I write down here? I can't even see my own handwriting. I wrote, oh, bathing. They may be able to do some bathing. I kind of squeezed it in. That's what that says. That says bathing. All right. At this point at C7, they can do depression transfers. So remember at C6 up here, they could do independent sliding board transfers. Well, now they can do depression transfers, which is where you can kind of extend your elbows, because you have elbow extension now, and you can kind of scoot like this from one surface to another. So you can scoot from the bed to the wheelchair without that sliding board by using depression transfers. And at this point, they can live independently at home with modifications, which is huge, huge, huge. Alrighty. C8, the last one on this board here. This is finger flexion. And at this point, they're independent in all ADLs.